Hi, my name is Shaji Kumar. I'm a hematologist at Mayo Clinic in Rochester, Minnesota. Today, I'm going to talk about the optimal approach to treatment of a patient with newly diagnosed multiple myeloma. As many of you know, myeloma is the second most common hematological cancer, um, with about 40,000 people or individuals diagnosed with this condition annually in the United States and over 100,000 across the globe. Now, multiple myeloma is a cancer of the plasma cells, which is a subset of white cells that's predominantly found in the bone marrow of normal individuals. These white cells have the task of fighting off infections by making antibodies against foreign substances. Now, the onset of multiple myeloma is typically preceded by a precursor phase that is often referred to as monoclonal gammopathy of undetermined significance. Now, this is much more common than multiple myeloma and can be seen in as many as 6 to 8 out of 100 individuals over age 70. And the prevalence of this precursor condition increases with age. Only about 1 in 5 of those individuals diagnosed with a monoclonal gammopathy of undetermined significance will eventually develop active myeloma or a related condition that requires treatment. Now, the progression is typically characterized by increase in the amount of that monoclonal protein or immunoglobulin that is secreted by the abnormal cells, as well as the increase in the percentage of abnormal plasma cells in the bone marrow. Now, the reason why we need to diagnose and watch these precursor conditions closely is because of the risk of progression to active myeloma. If you look at the monoclonal gammopathy of undetermined significance, only about 1% per year will go on to develop myeloma. Now, there is an intervening phase referred to as smoldering multiple myeloma, where nearly 5 to 10% of the patients can develop active myeloma each year over the first 5 years, less frequently of the subsequent 5 years, and then about 1% per year after that. So it's very important that we make the accurate diagnosis whether the patient has active myeloma that needs to be treated, which includes presence of bone lesions, anemia, kidney problems, or certain markers such as the percentage of plasma cells in the bone marrow, abnormalities on the imaging studies, as well as the serum-free light chain testing that can demonstrate a significant skewing or high ratio that suggests that the myeloma is uh, requiring to be treated or the patient has active myeloma. If patients has monoclonal gammopathy of undetermined significance, we typically watch them. While patients with smoldering myeloma, increasingly clinical trials are starting to show that if there's a very high risk of progression, then we should probably treat those patients rather than wait for some of this end organ damage to happen. Now, the outcomes of patients with myeloma can be quite different depending upon the underlying genetic abnormalities present in the myeloma cell. Now, these genetic abnormalities typically includes switching of portions of chromosomes between each chromosome, like what we call the translocations, or they can be increased numbers of chromosomes, especially odd-numbered chromosomes called as trisomies. Now, in addition to these primary abnormalities that are typically present in all myelomas, over time, myeloma cells acquire additional genetic abnormalities that then makes the disease more aggressive. Now, based on the presence of these cytogenetic abnormalities, we can actually group patients into multiple groups with very different outcomes. And as you can see here, we use some of the genetic characteristics, some laboratory testing like LDH, which is tested in the blood, beta 2 microglobulin in the blood. And all these different uh, results can be compiled into development of these staging system with very different survival. Similar approaches have been done by our own group, where we have looked at these genetic abnormalities as well as presence of elevated LDH in the blood or high beta 2 microglobulin in the blood, and again can identify three to four different groups with very different outcomes. The reason why we want to identify the high-risk patients is these are the patients who tend to go through different treatments much faster, become resistant faster, and often have a shorter survival. So we want to try and treat them in a more aggressive fashion.